Welcome to a new episode of Science in Context. I'm Sabine, and this week, Oliver Stevens joins me to speak about HIV and key populations in sub-Saharan Africa. Oliver, what are key populations?
Key populations are groups at high risk of HIV acquisition and transmission, and they're called key populations because they have both a high biological risk, but also a high socio-structural risk. So in this analysis, we're talking about female sex workers, men who have sex with men, people who inject drugs, and transgender people who may have significant legal and social adversity, as well as their biological risk as well.
Your work presents a unique collection of data and estimates for key populations. Why are these estimates so important?
So I think there are two things that are of note here. One, we've used a large body of peer-reviewed data, as well as a large body of grey literature, which are what we call survey reports and so on, which might be made by ministries of health, but they never reach the peer-reviewed domain. So we've used a really wide and rich body of data for this work. The second thing is that in many countries, for many of these key populations, local surveillance data doesn't exist. And so we've used our models to extrapolate from settings that do have data to settings that don't have data. So in many cases, these estimates will be the first available for key populations in some countries in sub-Saharan Africa.
Given the limited availability of data, what is needed going forward?
We can always clamour for more data, for more surveys, for more money, and that's all well and good. But I think it will require much more wholesale structural change. So UNAIDS has something called the 10-10-10 targets, framed around stigma and discrimination. And much of that work will have to be done before these highly marginalised key populations feel comfortable and feel safe engaging with surveillance and health systems, which will then eventually lead to higher quality data. The second big transition that needs to happen is we have to start using more routine data rather than survey-based surveillance, by which we mean data that we can derive from health facilities as the health systems in sub-Saharan Africa to strengthen over time.
Thank you so much for your time today.
Thanks.